All right, let's dive straight into this explainer. We're going to be translating some incredibly dense pathology into an accessible scientific story about exactly why our backs hurt. Because, if you've ever dealt with back pain or know someone who has, you know just how ridiculously frustrating the whole diagnostic process can be. Today, we're unpacking a massive paradigm shift happening right now in how medical science understands spinal degeneration. Section 1. The back pain mystery.
Okay, here is a totally counterintuitive fact for you. Degenerative MRI findings, things like disc desiccation or a loss of disc height, are actually incredibly common in completely asymptomatic people. Seriously, you could pull someone off the street who has zero back pain, put them in an MRI machine, and find what looks like a severely degenerated spine. Which, of course, begs a massive clinical question. If the degenerating disc isn't the sole culprit for a patient's pain, what on earth is? That brings us to this really fascinating comparison, which perfectly illustrates the classic imaging symptom mismatch. On one hand, you've got patients with terrible-looking scans who feel perfectly fine. On the other hand, you have patients in debilitating pain who only show mild findings on a standard MRI. It's a stark reminder that we simply can't look at imaging phenotypes, like an isolated bulging disc, as direct pain generators. We've clearly been missing a crucial piece of the puzzle here.
Section 2. Shifting the MRI paradigm. So to really wrap our heads around this new framework, we first have to define the old standard, which radiologists call modic changes. For decades now, doctors have looked at these modic changes to identify abnormal signals in the bone marrow right next to the disc. Type 1 might show edema or inflammation, type 2 shows fatty changes, and type 3 shows bone sclerosis. But here's the catch. Modic changes primarily focus on that isolated marrow signal, rather than evaluating the entire area as a continuous, interconnected lesion. Now, what's really interesting here is the conceptual leap from evaluating that isolated marrow to looking at a continuous disc end plate marrow lesion. This new framework is called the DEBC classification. That stands for the disc end plate bone marrow complex. So instead of just flagging a marrow abnormality and calling it a day, DEBC integrates the disc signal, the integrity of the end plate dividing the disc and the bone, and the marrow response, all at once. It's a much more holistic view. The big takeaway here is that by using a specific type of MRI scan called STIR sequences, which are basically fantastic at spotting edema-like active inflammation, we can categorize these complex lesions into types A through D. Type A represents high activity and edema, all the way down to type D, which shows low signal sclerosis and chronic structural remodeling. Now, we do have to humbly remember that these are just radiological hypotheses right now, not actual histopathological diagnoses, but they still give us an incredibly powerful new lens to categorize the active state of the spine. Section 3. A connected spine ecosystem. This definition right here, it's absolutely vital. The cartilaginous end plate acts as a highly regulated border wall between your spinal disc and your bone marrow. See, the disc itself actually doesn't have a direct blood supply, so it relies entirely on this end plate to act as a filter, letting good nutrients in and clearing metabolic waste out. When this border wall fails, well, the entire neighborhood suffers. And this schematic beautifully visualizes that structural breakdown. We can see exactly how end plate disruption, calcification, and tiny microscopic fractures drive this interface-centered degeneration. Basically, when that end plate cracks or hardens, it takes a small, local structural defect and turns it into a massive cross-tissue crisis. So what happens when that nutrient barrier breaks down? The disc quite literally starves. We see a dramatic drop in the diffusion of vital glucose and oxygen. And at the exact same time, metabolic waste gets trapped. This creates a low-nutrient, highly acidic environment that just completely shuts down the tissue's ability to heal and synthesize new matrix. Section 4. When inflammation won't stop.
Let's map out this disease loop, because it's essentially a self-amplifying cycle. First, the end plate injury weakens the barrier. Second, this exposes fragments of the degraded disc matrix directly to the bone marrow. Third, the marrow's immune system spots these fragments, assumes there's massive damage, and triggers heavy immune cell infiltration across the border. Now, in a normal, healthy body, this inflammation would clear out the damage and just turn off. But here, it simply fails to turn off.
Just look at the sheer complexity of this multicellular network that gets locked in this battle. You've got macrophages, T cells, and this endless exchange of cytokines. The stressed end plate cells actually actively recruit these marrow immune cells. It creates this chronic, low-grade inflammatory feedback loop where immune cells trigger structural remodeling, which triggers nerve ingrowth, which then just triggers more pain and more inflammation.
The real biological question we're facing isn't just how this inflammation starts, it's why it fails to resolve. The crucial point is that an active DBC lesion represents a state where inflammatory activation unfortunately coexists with a total failure of inflammatory resolution. The body is desperately trying to heal an injury, but because the mechanical stress and the structural breakdown are continuous, the biological alarm bells just keep ringing and ringing.
Section 5. The future of spine care. Now, we really have to maintain some scientific humility here. As the researchers explicitly point out, just because we spot an imaging active interface lesion on an MRI using this DEBC framework, it does not automatically mean that the lesion is the dominant pain generator for that specific patient. Pain is incredibly subjective. It can stem from muscles, nerves, or even central sensitization. These evidence boundaries are a great reminder that DEBC is currently best used to improve patient stratification for future clinical trials, rather than acting as some magic diagnostic cure right this second. It allows researchers to group patients who actually have the exact same biological subtype of degeneration. That way, we can finally figure out which specific anti-inflammatory or regenerative treatments work for which specific type of lesion. So that brings us to our final thought for this explainer. How will viewing the spine as an interconnected ecosystem fundamentally change the next decade of back pain treatments? Think about it. If we stop treating the disc and the bone as totally separate entities and start treating the entire interface as a whole, we might just be on the verge of a true medical breakthrough for millions of people. Something to ponder.